Hi, and welcome to this webinar about relapse prevention planning in a collaborative care setting. My name is Sara Marasco, and I'm a training and implementation specialist with the Michigan Collaborative Care Implementation Support Team. We look forward to sharing a little bit about relapse prevention planning today. So in a number of different patient care programs, including care management programs, it's common where we have to reach this point where we say goodbye to our patients. And oftentimes that's for a good reason. They've gotten better, they've reached remission, and it's time for both of you to part ways so that you can maybe open up your caseload to accommodate new patients that could use your help. And so at this point, I encourage you to think about your experience with wrapping up patient care. And, if you do have experience with that, what has that been like for you in the past? Oftentimes we hear a lot of different experiences, and sometimes providers talk about how it can be difficult to say goodbye to patients, and sometimes it can feel like a relief. Sometimes there's a sense of pride with saying goodbye, and sometimes we feel a little bit nervous even to say goodbye to our patients. I know that myself, as a former care manager within a collaborative care program, that sometimes it was difficult to say goodbye. We work with patients sometimes for 3 months, sometimes for 12 months, and we form these bonds with them, and we get to learn each other a lot, and we really want them to continue succeeding, and it can be hard to sort of wrap up care and know that they're going to move forward without close care management. And then sometimes we have mixed reactions with patients as well. Some patients feel really ready, and some patients feel a little bit nervous and are a little bit apprehensive about moving forward without having regularly scheduled care management in their lives. So we think about this idea of sort of discharge planning, and a lot of different programs, whether care management or therapy, have different protocols for what we do when we're saying goodbye to patients. But we do know that it can often feel better to the provider and the patient and associated providers like the primary care doctor or primary care provider to have some sort of plan in place that we know we can reference and that the patient can reference as we do wrap up care. And we do know that when we're treating patients with depression and anxiety and other behavioral health conditions, that recurrence can be really normal and can just be a part of having these types of conditions. So, for example, we'll focus on depression here, as that's so often the focus of collaborative care treatment. But we know that depression, among other behavioral health conditions, is often a chronic condition for people. So just like diabetes, it can be something that needs to be managed throughout a lifetime in order to prevent it from recurring or from getting worse. And so we can see here that at least 45% of people with major depressive disorder experience recurrences, typically with 7 to 8 depressive episodes over the course of their life. So recurrence is something that we want to make our patients aware of as a possibility, and we want to be thinking about as well, and having that to help inform our care planning as we wrap up care with our patients. Now, some of you are probably already familiar with the trans-theoretical model of change, but I throw this up here just briefly today to remind us that in several versions of this model, we will often see relapse as one of the stages of change. So some of our patients may make their way through these stages and get to the maintenance phase and be doing really well. And some of our patients may even make their way to the relapse phase and kind of move through the stages beyond that. So just remember that relapse can be part of the normal cycle. It doesn't necessarily have to be an outlier. It doesn't have to be looked at as a bad thing, but just maybe one of the stages that some of your patients may reach. So that reframe can help us to kind of emotionally prepare for that if our patients do relapse or start to feel worse again or have an onset of depression and anxiety. And it can also help us to prepare for having those conversations with our patients and normalizing it and getting them to think about what they might do if that does happen for them. Sometimes as we talk about relapse prevention planning with different clinicians and care managers, the idea of the language of relapse prevention plan comes up in conversation. Relapse is often something that's used in more of a substance use context, and we've even had people mention that it can feel like more of a negative term, and some people feel completely fine with it. And I think what we would most stress here is that, number one, there are other words or terms that we can use to have these conversations and fill out these plans with patients. And that could be anything from recurrence to just calling it a self-management plan or a safety plan or whatever, kind of feels right to you and your patient. But we would encourage you to just have that conversation with your patient that it's all about what's most helpful to them. You can give them some ideas of what to call it, and let them even decide to name their plan. So we always want to go for patient-centered care, and this is just one more example where we can kind of look to them as the expert to decide what they'd like to call it. So with that, what is the purpose of a relapse prevention plan? So really the main point of this whole thing is to prompt a conversation about the possibility of symptoms returning. So we've already talked about how we want to have that conversation about recurrence and how that can happen with depression, anxiety, or other behavioral health conditions. Sometimes it can be helpful to, equate it with the idea of a chronic condition like diabetes or hypertension, maybe something else that your patient specifically is managing that can help to, give it some context and help explain it. The purpose of this plan is also for patient empowerment. So we want them to have a tangible plan that they can walk away from care with and know what it is that they can do to continue managing their behavioral health, managing their well-being, and knowing what to look out for and what to do if something starts to head down a road where they need more support. The purpose of this plan is also to remember together what has worked really well for the patient. So we're at this point because they've seen some positive change, and it can be really wonderful to reflect on what's been helpful and what has helped them get to the point where they are today. And also the purpose is to plan for the future. So what do they want to continue working on? What do they want to look out for? And what can they do if they do need more support in the future? So when is a relapse prevention needed? Now, there can be a couple of key time points here, and I will say that there's always the caveat of you're a trained clinician, you know how to work with patients within collaborative care, so trust your clinical judgment. And also remember that you likely have a clinical supervisor to talk to when you need some guidance, and you are also reviewing your patients with your psychiatric consultant on around a weekly basis. So they're a great reference as well to decide when to approach this stage of care. But the first category that I'll focus on here is sustained remission. So these are patients that have scores of less than 5 on the PHQ-9 or GAD-7, and they've really maintained those scores for 1 to 3 months. Additionally, we have sustained response, which is a little bit different. It's a 5 or more point reduction from the baseline PHQ-9 or GAD-7 scores, or a 50% reduction of scores from their baseline. So this is another kind of way to look at clinical improvement to the collaborative care program. And if patients are maintaining that response for 1 to 3 months, then that can also be a really good time to do a relapse prevention plan. Not everybody's going to get to remission or be able to stay in remission for 1 to 3 months. So looking at response is another great way to evaluate if your patients are kind of ready to have this conversation and move forward into the next phase with their relapse prevention plan in hand. I will also touch on a couple of these categories in the bottom. So sometimes we'll do a plan with patients when they haven't reached sustained remission or sustained response. And I will say that in that case, we probably don't want to call it a relapse prevention plan because maybe our patients haven't gotten to a really low score level or a really sustained level of well-being. And at the same time, we do need to recognize when patients have kind of gotten as much as they can from the from the program, and knowing that you need to at some point open up your caseload to admit more patients on that you can help. So some of these patients are those who have just gained maximum expected benefit from the program. And I can't stress enough that these are often the hardest ones to know when to do a plan and move them on. So use your supervisor and use your psychiatric consultant to make this decision. These are often folks that have chaotic lives or a substance use disorder that, they're not ready to make any changes around. Maybe patients with personality disorders, etc. So you've been working with them for a while and they're really just not engaging or not responding to treatment, and maybe they aren't willing to connect to a different level of care, and it's just time to have some kind of plan in place and move them on. Also, we'll want to think about patients who have been referred to and are agreeing to connect to a higher level of care. So those are often patients that you might be referring to specialty care in the community or community mental health services, just because they need a little bit more than what collaborative care can provide. Now, before we jump into how to talk to our patients about relapse prevention plans, I wanted to share a quick example of what a relapse prevention plan can look like in terms of content. And as you can see, it's nothing fancy. These are usually the main categories that we'll include in relapse prevention plans. And of course, you can personalize it and add to it and subtract as you and your patient decide. But the common categories include the patient's name, the date that the plan is filled out, any medications that the patient's taking, any other treatments, which can often include support groups or therapy, personal warning signs, so signs that the patient might notice about themselves or their lives that indicate their depression or anxiety or behavioral health condition is worsening, as well as things that they do to prevent or manage their behavioral health condition. We also like to make sure to include key contact information, including for their primary care provider, their care manager, maybe anybody else on their care team that's pertinent, as well as emergency contact or crisis numbers. You can even choose to include their next appointment time so that they know when to return to the clinic. So getting down to the discussion with the patient, how do we start talking about relapse prevention planning? Well, I will say that, just to rewind a little bit, when we're enrolling patients in a collaborative care program, one thing that we always want to do from the start is to remind them that this usually isn't going to be a forever thing, and the goal is to get them to the point where they are independent of care management again, if possible. So once we get to this point where we're starting to bring up relapse prevention planning, we're sort of revisiting that idea and framing this really positively, because this is progress and this is where we wanted to get to. So having a congratulatory or almost cheerleader tone, that can be completely appropriate at this point. Get the patient excited that they've made all this progress and worked so hard and that it's paid off. Again, we also want to share that depression and anxiety can kind of come and go. It can ebb and flow over time. Some people may never experience it again, and some people may experience it multiple times, and it's all normal, and we just want to be prepared. So we want to frame this again as an empowerment tool. So explain that we're going to go through this conversation and fill out this plan together so that they can focus on doing what works well for them, looking out for signs to increase their level of support, and just really knowing what to do if things start to feel worse. And we also want to explain to the patient that we want to get their ideas for how to use the plan. So we can give suggestions for what other people have found helpful in the past, but how do they imagine it fitting into their lives? Where would they like to keep it? Would they like to post it on their wall? Would they like to hang it on their fridge? How often do they want to look at it? Do they want to share it with any other members of their family or their support system? So when we're having this initial conversation, just help them start to envision how this plan might fit into their lives and how they can best utilize it. So we can actually just use our written copy of the relapse prevention plan to prompt the conversation between you and the patient to start filling it out together. So we usually want to use open questions, again, to elicit the patient's ideas about each of these categories. So I won't go through every single one of these questions that's listed on this slide. We actually will have the slides up on our website, so you can reference this if you would like a copy. But here's some examples of ways to get patients thinking about these different categories. So a couple that I might focus on are under personal warning signs. We want to get patients to really think about what it's like for them when they're starting to feel worse. So rather than just asking one question about warning signs, we might really get specific and say, what thoughts might you start to notice? Or what might you stop doing? What would your sleep look like? What might be different about your day-to-day? Get them really to remember what it was like for them when they were in the depths of their depression or anxiety or other behavioral health condition, and try to jot these things down so they can remember and feel ready. Same thing with preventing or managing depression and anxiety. We can ask them generally what works for you, but we can also kind of get them to think about specifics. What do they like to do? Who do they talk to? What do they think about? Generally, what helps you be the best version of yourself? Or maybe even what are some things that you want to try doing? They can put future-oriented ideas on here. So there are definitely more open questions than the ones that are listed here, but these are just some examples to get your thoughts going about how you can use this tool to have a really good and often enjoyable conversation with your patient about their history and what they'd like to keep doing as time goes forward. Let's just take a quick moment to think about the format of relapse prevention plans and what might be most helpful or what's possible. And the answer to that is really any format is okay, as long as you are, number one, working on these plans collaboratively with the patient. Number two, asking the patient what they think will be most helpful to them in terms of format. And I'll add a number three, making sure that you are making a copy available for yourself and the rest of the care team to reference in the future. So whether that's typed directly into the electronic health record or scanned in, just make sure some copy is available for reference. So the format can vary depending on your tech capabilities, depending on if you're sitting in person with the patient filling this out, or if you're filling it out over the phone. So you might be writing it up together on a printed out worksheet you've created. You might be typing it. You might be writing it while they're telling you things over the phone and then mailing them a copy. Really, any of these things works as long as the patient agrees to a format that they most prefer and could see themselves referencing most easily. So that's pretty much it. As you can see, relapse prevention planning is not the most complicated concept, and it can be pretty intuitive, especially once you have that template right in front of you to kind of start prompting the conversation and working you through these questions with your patients. So I will just reiterate that this is often a really exciting point to get to with your patients if they have reached remission or responded to treatment. So remember the progress and the hard work that both of you have put in, and I hope that you enjoy the process. We do have more resources available on our website, which is listed here. These slides are available, as well as a written guide to relapse prevention planning, which can be found under the BHCM training page and resources for providers as of the recording of this webinar. We also have a patient fridge flyer called What Can I Do? It's kind of similar to a relapse prevention plan and helps patients think through different situations with how they might be feeling and how they can respond to different feelings. And we also have templates for relapse prevention and self-management plans, so for whatever you want to call it. And you are welcome to use those as are. You can print them out and use them in your clinic, or you can use them as ideas to modify them and make your own, whatever you decide. We also have large print versions available of those for folks who have impaired vision or older adults, if that's helpful. If you have questions, feel free to reach out to me. You can find my contact information as well as contact information for the rest of my team on our website. And I thank you for listening today, and happy relapse prevention planning. Enjoy the process.